CVS Part 1 Case 6.
A 68-year-old female with HFrEF, EF is 18%, ischemic cardiomyopathy post-CABG, CKD stage 3A, baseline creatinine was 1.6 and hypertension, presents with ADHF exacerbation. Initial profile was cold and wet, BP was 85/55, JVP 10 centimeters, edema is 3+, creatinine rose to 2.4. Treated with hydrochlorothiazide, non-invasive ventilation, dobutamine and continuous furosemide. After 72 hours, net negative was 12 liters, BP was 102/68, JVP is 4 centimeters, lungs clear but new oliguria despite euvolemia. Labs include creatinine 3.8, NGAL 450, potassium is 5.8, BNP is 60%. Right heart catheterization includes PCWP 14 mmHg, RAP is 6, cardiac index is 2.3, SVR is 1200 dynes, PVR is 4 Wood units. Echo shows severe TR, RVSP is 55 mmHg, IVC is normal. Urine sodium is 12 and FeNa is 1.2, no sediments. What is the single most appropriate pathophysiological diagnosis and next management step? Option A, CRS type 1 is CRS type 1. Management includes renal replacement therapy. Option B, CRS type 3. Management, reduced diuretics. Option C, right ventricular maladaptation with venous congestion. Management is IV milrinone plus sequential nephron blockade. Option D, tubuloglomerular feedback from loop diuretics. Switch to acetazolamide. Option A, cardiorenal anemia syndrome. Management, erythropoietin plus iron infusion.
Yeah. This is a case of acute decompensated heart failure where after the decongestion we have achieved euvolemia, which is marked by a normal PCWP, which is 14 mmHg, and a normal RAP, but a raised pulmonary vascular resistance. This raised pulmonary vascular resistance becomes a reason for increased RV afterload and leads to backward congestion, venous congestion, which leads to renal hypertension and functional impairment of the kidney. So we can see here that this raised PVR which is becoming the raised afterload for RV, leading to renal hypertension and functional impairment of kidney, becomes a reason for type 5 CRS. Now management, coming to the management, what we will be giving here is we will give IV milrinone plus we will be doing the sequential nephron blockade, because milrinone is an inotrope as well as it is a pulmonary vasodilator. We need to maintain the perfusion. Post decongestion we have achieved euvolemia, but we need to maintain the perfusion. To maintain the perfusion we need milrinone, and to deal with the pulmonary vasodilation also we need milrinone, as it will lead to pulmonary vasodilation which will decrease the PVR, and the afterload for the right ventricle will also get decreased, and the backward congestion which is leading to functional impairment of kidney will not happen. So this is the mechanism by which milrinone will work. And furthermore, as we have observed that the response to distal tubular glomerular feedback, the distal tubular glomerular feedback is more dominant than the proximal tubular glomerular feedback. So a sequential nephron blockade with the help of diuretics like thiazides will be done. Now coming to the correct option and excluding the wrong options with Dr. Sarita. What is option A?
CRS type 1.
So we know that this is not CRS type 1.
And the management is renal replacement therapy.
Yes, and renal replacement therapy is the last step in the management. If everything fails and hemodynamic stability is not there and the patient is not responding to the current treatment.
Option B, CRS type 3. Management is reduced diuretics.
So this is not CRS type 3, and reducing diuretics can further lead to congestion. So we will not be doing that.
Option C, right ventricular maladaptation with venous congestion. Management IV milrinone plus sequential nephron blockade, which is the right option.
This is the right option. This is a RV maladaptation leading to venous congestion and renal hypertension, and the management is by IV milrinone and sequential nephron blockade.
Option D is tubuloglomerular feedback from loop diuretics. Switch to acetazolamide.
Yes. So acetazolamide will not be a option here because it will lead to the proximal, it will take care of the proximal tubular glomerular feedback and not a distal glomerular feedback.
Option E is cardiorenal anemia syndrome. Management is erythropoietin plus iron infusion.
So management with erythropoietin and iron infusion is a long-term option, and this will not give a quick relief to the patient. So this again gets ruled out and is the wrong option. Thank you.